Thank you very much. So I was talking to Surf about this morning about what we're going to talk about. I'm going to cover my kind of specialty bronchoscopy. So in the previous talk, I spoke about different ways to navigate and what is available right now. You have the radioprobe, you have the ultra-thin bronchoscope, you have the navigation system, which you don't have the right knowledge of the anatomy. But what if you don't have all of that? And in addition, if you wanted more control out into the periphery, I think from the videos that I showed you, you kind of got an idea that I can go out, even leave the sheath in the periphery of the lung, but we're kind of limited when we do biopsies, nodules that have a certain bronchus that's leading into the tumor. I think some of this problem may be solved with a robotic bronchoscopy system. So it may look like this. Imagine the patient will probably have to be under general, probably in the operating room because it's a robot. So it's for us, potentially. And there's several, two actually systems that are being developed, which I'm going to briefly introduce. So the problem with the diagnosis of solitary pulmonary nodules is not all lesions are visible on fluoroscopy in this study. Only 60%. Spiculated lesion with the border, 60%. This is the issue. Bronchus sign present on the CT, out of the 1,000, only about 48%. But in reality, I think when we look at all tumors that we're dealing with, the peripheral nodules, the lesions that actually have a bronchus sign is probably less than 10%, I would think. And the diagnostic yield with the bronchoscopy with radioprobe ultrasound or the navigation system really heavily relies on whether there is a bronchus that goes into the lesion. If there is no bronchus sign, the yield is like 31% versus 79% when you're using a navigation system. With the radioprobe, 48% when you have an eccentric view, meaning you have the probe and the tumor is like adjacent to it. So that's, I think, the issue and kind of the limit of what we can do. Size, obviously, is an issue, and again, relationship with the airway. So this is a radioprobe here and the tumor. You can see the bronchus is adjacent to the lesion. That is more challenging. So how can we solve this? And this is the intuitive robotic bronchoscopy, and this you can find online. I just downloaded this video, and there is sound to it, but I guess we're not hearing it. Oliver is one of the thoracic surgeon that is, I think, now the medical director of this intuitive, and they have been working on a robotic platform, and they showed this on the website. This is what it's going to look like. You see the patient, well, that's the CT scanner. I think in the video you'll see a glimpse of what the robotic bronchoscopy system may look like. So there's the bronchoscope going in. You can actually see where you are. Likely it'll have a navigation system that will allow you to go into the periphery. But the biggest difference between a regular bronchoscopy is that you don't have to hold on to the bronchoscope. You will probably be working on a controller, just like playing a video game. You can probably advance your bronchoscope in and out with a built-in bronchoscopy system. So that's the intuitive. That's all that is available. Another company, Auris Surgical Robotics, And they're focusing on endoscopic robotic technology, and one of the first of their initiative has been the bronchoscopy, and I think they're looking at other areas of endoscopy. And this shows kind of the platform of their device. These slides were provided by Oris, and some of this I presented at the previous SDS TechCom meeting. And this is actually, it's called the Monarch, the system, and this is the device that's going to be a controller. So anyone in here play video games like the, yes? Have you seen this? It's kind of like the games that we do, but I've never played a video game in my life. And I actually went to Oris and I kind of played around with their device, but even a non-game player, it was very easy to use. And you don't have to, you can just sit down and watch and move this. And it looks kind of similar, I think, to the intuitive system. This is the actual robot, and you have the endoscopic view. You have your CT view, which will tell you where you are, and you have this bronchoanatomy view, and you can kind of switch this around. And this is a video that kind of shows you what it looks like, similar to the intuitive. So patient is probably going to be intubated, and then you go in with the system using your hand device. You can navigate yourself. So I think going into the segment is easy, right? And then going into the sub-segment you can do with the ultrathin, but beyond that I think that's the issue, the reach. And when you're here with the bronchoscope, you can't really make the turns. Making this turn in the tip is almost impossible. So I think that's something that the robotic technology will probably likely be able to provide, which is not possible with the current bronchoscopic system, whether it's the Super D or whatever you have. So you have good reach, access to peripheral nodules, probably more than even an ultra-thin bronchoscope. Vision, when you do peripheral bronchoscopy, once you're in the sub-segment, you lose your vision. So you have to kind of push your bronchoscope, and you really don't see that well. But with this system, hopefully we can see. And control, so precise instrument manipulation. So you saw it in the video, even in the periphery, you can kind of move the tip of the robot so that you can target the lesion. So this is a study that they did where they compared the Olympus P190. If you remember from my previous talk, P190 is a 4.2 millimeter thin bronchoscope with the 2 millimeter channel, and approaching the same lesion with Olympus versus the Monarch, you can see that the robotic system will go out further. And one of the reasons that that's possible is that with the bronchoscope, there's two bending portions, but that's it. With the robotic system, you can go out and then you can do another turn. I think that allows the system to go out further. Look at the left upper lobe, P190, that's a limitation. And for the left upper lobe, that's always an issue because even if you try to push the bronchoscope into the left upper lobe, since there's a great angle, all you do is you're going to be pushing the bronchoscope this way. It will never go out that way. But with this system, since it's a different platform, you can basically go out really far out into the periphery. On the left lower lobe as well. This is a video of the actual endoscopic image, bronchoscopic image. They measured the distance from the pleura, you can really go out very far. So, and this is in a cadaver. Images are pretty clean, going out sub segment. I think with a regular bronchoscope, you lose your view at this point. And oftentimes it's because you're just pushing the bronchoscope and the tip will kind of hit the wall. But with this robotic platform, you can really stay right in the middle. So this is probably easier than what you think. And you don't have to stand there, you just kind of look at the monitor and move your device. So I think this is really the future. Real-time peripheral vision. So this is really a video that is out into the periphery. And I have never seen images like this. And you can see how the tip is moving around so that you can kind of target and you can move the tip if you wanted to do the biopsy. And then you can put your needle in. Frank, if you can click on this video right here, and then you'll see the needle go in. So this is very precise, I think, and actually the vision, the quality of the image is actually very good. And this is just in a phantom. And you can kind of see how this system works. You're going out. And I think this is is it a dollar bill? Or I'm from Canada, so I'm not sure what kind of it's an American dollar, I know that. And so you're out, and if you can click on this. So now we're at the dollar bill. Will it move? See how fine it is, and you can kind of direct your needle. If you want to hit that eye, you can hit that eye. So it's pretty neat, I think. And this is not possible with the current bronchoscopy system. And their system, they have a unique navigation. It's a fused navigation system where they use optical pattern recognition throughout the procedure. They feed it into the robotic data, and they also have the electromagnetic navigation. So you don't have to think about anything. The robot will really give you all the information and put all of that into this platform. They did a cadaver trial targeting eccentric lesions, and eccentric versus concentric. This is something a term that we use when we're talking about the radio probe. Eccentric is where the probe is adjacent to the nodule. Concentric is when you can place the probe right inside of the tumor. This is obviously, we have a high yield. Overall, 24 synthetic nodules were targeted with the robotic system. Overall yield 92%, with concentric 100%, but even in the eccentric, so even if the nodule is kind of adjacent to the bronchus, very high yield. They took the first edition device to Costa Rica, probably for various reasons, because they can do it in patients. And they did 15 patients for suspected lung lesions. And looking at the images, it's very amazing because this is really out into the periphery. And the surgeon doing this has not much of a experience with bronchoscopy, yet they were able to really get the diagnosis. So I think this is really interesting platform. And when you combine this with the therapeutics, I think it's going to be a game changer. If we're just using this very expensive device, I don't know how much this is going to cost. But $500K, And you are? Okay. Okay. Well, I kind of knew, but I wasn't supposed to say, so I didn't say it. So just
Politically perfect, Kazu.
yeah. So it is going to be, not as expensive, but 500K for this. If you're just using this for diagnostic, I think it's too expensive. But if you have different options, imagine if you can approach the peripheral nodules, and the catheter is going to be there, and you can deliver cryo or RFA, microwave. Then you don't have to fight with the different companies. You can use everything to treat. So I think the robotic bronchoscopy may allow integration of different technologies in a interdisciplinary manner. And in general, I think the future is bright for the use of robotics in thoracic surgery. And I think Surf is going to talk about the surgical robotic platform. So thank you very much.